So, thank you very much, Paul. Thank you very much, everybody. I know you've had a long day, and I promise I won't keep you long. However, I am very used to being the final speaker of the day, because you've probably gathered by now, I actually speak about how we care for dying patients, how we care for people at the very final stages of life on a very regular basis. And, you know, I don't think I've ever spoken first, so I won't be at all offended if you have to leave. I promise I won't keep you long, but look, thank you very much for allowing me to come and talk to you. So there's just a couple of things I want to cover: the symptom experiences of dying patients, and then considering how we actually cover pain relief at the very end of life. Tired of living and scared of dying, and I use this quote because even though I know, and I know more than just about anybody in this world, that the mortality associated with life remains 100%. 100% of us are still going to die. And even though we know 100% of people are going to die, people remain fearful of death and dying. And if we look at the experiences of cancer patients, and you've had a lot about cancer patients today, we know cancer patients as a group have very high incidence of pain, and we know as a group also has a very high incidence of breathlessness. And we also know that both pain and breathlessness increase the closer people get to death. And we also know by data that's been extrapolated from patients being cared for in lots of care situations that pain and breathlessness remain the two most feared complications of dying. And we need to ensure that people reliably have access to palliation of such symptoms. But reliable access to such palliation is limited by inequitable access to palliative care services, and the fact that many healthcare providers remain challenged and ill-equipped by these problems. We actually know poignant data tells us that even though hospitals are the most likely place of death in our community, and although we know the data says that health professionals who work in hospitals acknowledge people are dying, the data tells us that these health professionals secretly, sneakily think that perhaps the best approach to care for this person is actually to continue life-prolonging treatment. And the problem is, if we continue life-prolonging treatment, failing to acknowledge the fact that this person is dying, we leave them at risk of uncontrolled symptoms. And we need to address these barriers. We need to consider the importance of such care, because there are a number of people who can be affected by this. If we fail to address patients' symptoms, we leave them, a very vulnerable group of people, we leave them at risk of distressing symptoms. We need to care for people properly because it's very slim evidence we have around bereavement. The one thing that we do know is, in fact, the experiences of people as witnessed by their families at the final stages of life. If families feel that we have cared properly for a person, they actually move better into their bereavement. These families are less likely to experience depression and are more likely to move through their bereavement without complicated problems. We also know from talking to lots of health professionals that they are confronted by caring for dying people. The majority of people, aside from people who work in palliative care, will have quite dilute experiences of caring for dying people. And these are not approaches to care that are readily available to everyone, and the experiences of people are not common. Melanie mentioned in her talk that she would actually like to see cancer pain as a focus for accreditation for hospitals. But I would remind you that in fact the quality of care that hospitals provide for dying people is actually already acknowledged as an accreditation standard, and the next round of standards when they're released, the quality of care we provide to dying people will be one of the issues that makes or breaks our hospitals moving forward. An important part of this is actually making sure that health professionals are equipped with the appropriate information. Now, a couple of years ago, when I started looking at the studies that tell us of the experiences of dying people, there are a number of systematic reviews, but no good big population studies using the same assessments were actually available. And as a result of this, with a group of my colleagues, I actually undertook a large population study I'm lucky enough, as part of my work, I actually work with the Palliative Care Outcomes Collaborative. And this is a unique project in Australia where we actually have 90% of palliative care services participate in a quality improvement project. This is a voluntary project, but part of the core of this work is on a regular basis we assess people's symptoms and we document this. And we've been able to show that by doing this across Australia, we can actually significantly improve the experience of patients. The other astonishing thing about this collaboration is we have access to large data sets that tell us the experience of palliative care patients at different time points. So I was lucky enough with some colleagues to actually look at the experiences of nearly 22,000 patients who had been identified as entering the very final stages of their life. And for the first time, we were actually able to look at this data to say, well, this is actually really what happens to people. Important to this conversation today, 75% of those patients had cancer. And not surprisingly, looking at people facing the very final hours of death, life, nearly 3/4 of them were 65 years or older, and about half were men. The terminal phase for this group, again, not surprisingly, was no longer than 2 days for the vast majority of people. We actually, as I said, we routinely collect information where we look at demographics. We actually look at the phase length, and phase for palliative care clinicians is talking about stages of whether or not a patient is stable, unstable, terminal, or actually dying. Performance status and activities of daily living. And we actually use some of this to undertake a regression analysis to see if there were factors in a patient's life that would predict them having worse symptoms. And I'm not going to talk about that today because I think the most important slide for us today, if we look at the range of symptoms people experienced, and these were patients who were suffering significant symptoms, which in my world is a score of 4 or more. The 3 top distressing symptoms were in fact fatigue, pain and breathing. However, if we actually looked at these figures in more detail, the vast majority of patients actually had achieved acceptable pain relief. Now, I'm not saying that it's appropriate that 20% of patients still had pain, but I know from this data that it was less than 2% of patients had severe pain. But this data becomes incredibly important because it suggests if we do obey the rules, we can actually look patients in the eye, and this is why this information is so important. I can actually look patients and families in the eye and say that I expect the vast majority of people at the very end of life will have very acceptable pain relief. And this is very important information that we can actually inform people. And I think one of the most important things that I do in my clinical day is sit with people and talk about what death and dying might look like. And that's why I think palliative care is absolutely pivotal and core to modern medical practice, that we have clinicians who have experience and insight and skills to actually sit with people and reassure them that they will be cared for, that they will achieve acceptable pain relief. Because for a lot of people, it is hard to die, but we need to say to people, but we will care for you, your symptoms will be acceptable. So I'm going back to the bedside now, and I'm going to finish with some very, very, very simple advice. And I'm sure many of you, and I can see a number of palliative care physicians in the audience who are going to say, boy, that was a bit lightweight. But I think we underestimate that people who don't work in this space don't have a lot of this information at their fingertips. So at the bedside, it is absolutely imperative that we monitor pain. I'm asked on a very regular basis by junior medical officers, I have a patient who's dying, what do I put in the syringe driver? What do I do? What do I put in the syringe driver? And I ask them to tell me the story of this patient. Tell me about this patient. Tell me about their pain control. What do they look like? Are they in pain? If they're not in pain, do they need pain relief? Why are we presuming based on a diagnosis that we automatically need to start medication? Why do we behave differently at the end of life as to how we would behave at any other stage of a patient's illness, where we appropriately observe people and we respond to their needs based on our observations? And if we start to frame care of the dying in the same format, that this is exactly the same as we will do any other stage of life, that we appropriately monitor people and we respond to their care needs, we are providing a far better service. Now, this is not only, as I've said before, a service to the patient, but it's also a service to the family. Interestingly, a number of years ago, I looked at the experiences of people in the acute hospital in the last 24 to 48 hours of life. Now, I actually found that nursing staff were very comfortable to go into the room and were very comfortable to continue taking blood pressures, temperatures and pulse. And families appreciate it, because what families want us to do is to continue to look after the person who is important to them. What we needed to do in that situation was actually change the observations that we empowered nurses to undertake, and we did that. And we were actually able to show that very comfortably nurses were very happy to go into a room and assess people's pain, breathlessness, nausea and agitation and family distress. And this had significant improvements in the way people were cared for, with simple things that we were able to significantly reduce the number of full blood counts that were taken in the last 24 to 48 hours of life. Simple stuff, very simple stuff, which can have major implications on the well-being of families after a person has died. And at the very end of life, all patients who require analgesia must have access to pain control appropriate to their past history of pain, their previous use of medications. In patients with cancer, the vast majority of patients will be on opioids. If a patient hasn't been on opioids, we need to look at their most recently available biochemistry. And we need to understand what people's pain experiences have been and what their medication history actually is. And most importantly, we need to consider the most appropriate route of administration. So if a patient has been on long-term opioids, we need to make sure that these opioids continue, but in a way that the person reliably receives these and safely. Do no harm. First rule of medicine, do no harm. And same as any stage of life, and I told you I was bringing you back to the bedside, I'm bringing you back to the very, very simple approaches to care, a stepwise and orderly approach to medicine. Mild pain, mild analgesia, strong pain, strong analgesia, and at all time considering the use of adjuvant agents. And I believe this is as appropriate when a patient is dying at any other stage of life. As I said, strong pain, strong analgesia, the vast majority of patients with advanced cancer will have severe pain for which they require opioid analgesia. And so these figures make it very unlikely that patients with cancer going into the terminal phase will not be already on opioids. And if they are on opioids and when they're no longer able to swallow, we need to consider a switch. Now, I am a very simple soul. I'm a very simple soul who's only going to talk to you for about 2 more minutes. But I go back to morphine. I go back to oral morphine. I use that as my basis. When we're looking at opioid conversions, mostly these studies are based on single-dose conversions in well patients. So use this with extreme caution, but go back to morphine and then move forward. And once you've moved to morphine, then consider the most appropriate parenteral analgesia. And for the vast majority of patients, we would use either morphine, hydromorphone or oxycodone, perhaps otherwise methadone if patients have been on that long term. And as I said, I think we should be considering adjuvant analgesia at the very end of life. Now, although the evidence to support some of the recommendations is not as strong as it should be, this is a group that is difficult to conduct quality research in, but there is no reason why we shouldn't be properly considering what this person's pain might be due to and making sure that we can continue appropriate medications or implement them. And we can do this if we consider the use of rectal analgesia, subcutaneous analgesia, or if people with the acute system, continuing IV analgesia. But certainly we can actually care for people at the very end of life using the same approaches to care that we would use in any other stage. Because what we have to do for people is make sure that the transition is not too troublesome. And I think that's one of the most important things that we can actually do. And that's all I'm going to say this afternoon. Thank you.
All right. Well, we're over time, but I don't know if anybody has a question for Katie or for Janet. otherwise we can go and have a drink. But before we do, thanks again for everybody attention today. I know it's been a very long day. It's hard to believe it's more than 8 hours since Charles first stood up here this morning. It's gone very fast. We probably packed too much into the program, but I also feel like we hardly scratched the surface on these issues. And my final thought is that when I first started working this field in the 80s, when did that we actually finished with the WHO ladder prior to Asimov's quote, but at the same time I remember Kathy Foley from Memorial St Kettering publishing a paper on the controversies or controversies of cancer pain management, and that managing cancer pain raises many medical, societal and moral or ethical challenges, and I think they'll probably never get resolved, but how we kind of try and approach them and deal with them does evolve, and I think we've had a very eclectic update on how we understand those challenges that we face trying to manage cancer pain in the context of the patient and the whole of society. So it's been a great day, and hopefully we can do it again sometime. Okay, so thanks again to the Cancer Institute, the Sydney Vital, and Professor Engel for allowing us to do the day. All right, so come and have a drink.